This is a case of a 70-plus-year-old gentleman with history of aortic valve insufficiency, thrombocytopenia together with stage 4 metastatic melanoma, and history of resection of melanoma from scalp with multiple areas of skin graft and also radiation to several regions of the scalp, who developed a solitary brain tumor which was initially treated with immunotherapy. However, he presented with progressive growth of this tumor despite immunotherapy, which resulted in dense right-sided hemiparesis and weakness, as well as expressive dysphagia, speech problems. MRI scan of his brain revealed a large brain tumor in the left frontoparietal region, accounting for his right-sided weakness and speech deficit. Anatomical review using MRI before the operation. On patient's right side, which is the left side of the screen, where anatomy is not distorted, we can readily identify pars bracket, anterior to which is central sulcus, sigmoidal hook sign, and motor strip. Now let's review the MRI slice by slice. Tumor has a lobular morphology with significant local mass effect and edema. Here is pars bracket sign and motor strip. Tumor has completely distorted the anatomy on the left side of the brain. Computer navigation is further used to study the anatomy and plan the approach to the tumor. Superior sagittal sinus and a large draining vein overlying the tumor is identified. Given the location of the tumor adjacent to motor strip and overlying large draining vein, we planned for awake craniotomy with cortical mapping. Patient's tolerance of an awake craniotomy relies on effective analgesia of the surgical area, which we will review here. Skip ahead if this does not interest you. So after prepping his scalp with chlorhexidine, his scalp was blocked, essentially made numb, by infiltrating local anesthetic agent consisted of marcaine and lidocaine mixture along the course of 7 involved nerves. These nerves are consisted of supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal, greater and lesser occipital, and finally great auricular nerve. Local anesthetic is injected along the dotted line marked on patient's scalp, the skull clamp pin sites, as well as incision sites. Let's have a quick review of anatomy of the blocked scalp nerves, which is quite important. But if this doesn't interest you, please skip ahead. Supraorbital notch can easily be palpated, and this is where the supraorbital nerve can be found. Supratrochlear nerve is just medial to the supraorbital nerve, above the brow line. Blocking zygomaticotemporal nerve involves infiltration at the lateral edge of the supraorbital margin to the distal aspect of the zygomatic arch. Auriculotemporal nerve crosses over the root of the zygomatic process of the temporal bone and lies deep to the superficial temporal artery. Avoid intra-arterial injection. To block great auricular nerve, inject the local anesthetic about 2 cm posterior to the auricle or ear at the level of the tragus. To block the lesser occipital nerve, infiltrate local anesthetic subcutaneously behind the ear, starting from the top down to the auricular lobule, and then continue to infiltrate along the superior nuchal line. Greater occipital nerve is found about 3 to 4 cm lateral to the external occipital protuberance along the superior nuchal line. While patient is completely sedated, a bone flap is raised over left frontoparietal region overlying the tumor. Patient is then awakened gently and maintained calm and comfortable prior to dura opening. So we have done the craniotomy overlying the tumor precisely, and we're gently waking the patient up. Dura is a little bit tight, but we want to make sure patient wakes up nicely. And this is the front, back, inferior, superior. Once patient is awakened and made comfortable, dura is opened gently and mindful of the large underlying draining vein. Are you in any pain at all? No? Good. Now, can you open and close your right hand so I can see it? Open and close your right hand. Make a fist and open. There you go, that's good. And can you wiggle your toes as well? Wiggle your toes?
Yeah.
Okay, good. You're in no pain. Can you say hello?
Hello.
Good. Everything's good. Under awake condition, we started cortical stimulation at 2 milliamp and increased it in 1 to 2 milliamp intervals using biphasic square wave at 60 Hz for 2 to 3 seconds stimulation with minimum of 4 seconds pause between each run, thus establishing safety of the surgical corridor. Next, the arachnoid overlying the large draining vein is carefully opened for temporary occlusion of the vein and examining whether its occlusion results in any neurological deficit. You're doing really good. You're doing awesome. And for... You have the microclip?
Yes, I do.
You're doing awesome. Okay, good. Now let's get the microclip. Microclip is used to temporarily occlude the large draining vein and the adjacent vein while patient is neurologically evaluated for a relatively long time with no side effects. Okay. Keep that for a while. Can I see another one?
Keep moving it?
Yeah, keep moving them.
Yeah.
Actually, if that one is going to be okay, the other one's going to be fine.
I can't quite move it.
Open and close your hand. You're doing great.
Both of them?
Uh-huh.
You got it.
There you go.
You have the other clip?
I didn't hear that. I didn't see
Great.
the operating room. The operating room is wide awake.
Now, can you open and close your hand? You're doing so well.
Yep.
One or both?
Just the right hand would be good.
Just this one, but you could do both. Yep.
There you
Good
go.
job.
And how about wiggling your toes? That's fine too? Oh man, you're just doing more than
Good
wiggle.
job.
That looks awesome. Great. Are you in any pain at all?
No.
Good. That's what. Are you comfortable?
Yeah. Nice
Okay.
and warm.
You're doing awesome. So now we're gonna. I think that looks pretty good. I think that's okay. I'm still gonna keep it alive, just because. Oh, now can I see your applicator again?
Are you talking to me?
You're doing awesome. Not right now, but
I can't quite move the right arm as much as I'd like. I am. But it's moving, but not quite as much as I'd like.
Looks like you're moving it pretty good.
okay. Keep irrigation, full
Try to
irrigation.
lift, push up against me here. With this hand.
Push up, with
Like
myself.
that. Yeah. There you go. Yeah, you're moving everything.
Everything's good?
Mm-hmm.
Moving arms and legs?
Yeah.
Beautiful.
Mm-hmm.
All right.
Want me to sing a song?
Please.
I can
What
only
you're gonna
do
say, you don't remember it.
I can only do Home on the Range.
See, that trick you played with me
That's okay.
again.
Oh,
That's
oh,
Dr.
wow.
Limonadi's favorite song, huh?
Deer in the antelope play,
There you go.
or seldom is heard, I can speak a screeching word, and the skies are not cloudy all day.
All right.
That's the only one I can remember, sorry.
Hey, that was pretty good.
That was awesome. And I'll let you go to Peter's. The sulcus between the two veins is used to approach the superficial pole of the tumor. Low current bipolar cautery and gentle suction is used to minimize trauma to the tissue. Computer navigation confirms that we are on lateral edge of tumor and specimen is sent for pathological study. Then the capsule of the tumor is hardened using low current bipolar and the tumor is elevated carefully with vascular supplies ligated prior to complete removal. Can you move your arm? Here,
I can't move it much more than this.
Okay. What about open and close your hand? There you go.
Is it bipolar?
What?
Open and close your hand. You're doing great.
Good job.
Yeah, no problem.
Mm-hmm.
Okay. Several vascular supplies. And Viper scissors?
Ready.
Are you talking to me?
Yeah, can you open and close your hand? You're doing awesome. You see a big vascular? Thank you. And this is big. Okay? Go. And ball irrigation, please.
You want me to do it more?
Can you open and close your hand? Very good. Moving?
Yes.
Good. Good. All right. Now we are going to need to go around and make sure everything is out. You took the bulk of the tumor. You did awesome. Resection cavity is carefully inspected to ensure there is no residual tumor. Sodium fluorescein microscopy is used as an adjunct to evaluate the resection cavity. Subcortical stimulation is used prior to any additional resection, especially in the anterior border of the resection cavity adjacent to motor strip. Patient surprisingly opted to stay awake during closure and had immediate post-surgical
And we
improvement.
removed all the tumor through a tiny opening. No tumors left. You have a choice of staying awake or go to bed
I want
or
to stay
sleep.
awake.
You want to stay awake? You're kidding me. You're the champion. Nobody's ever wanted to stay awake. Are you serious?
I want to do 15 pounds.
Good man. You're going to do awesome. Okay. But if you get uncomfortable at all, you let me know and we'll
Okay.
have you sleep.
Hydrogen peroxide solution is used for hemostasis as well as for therapeutic reason. The surgical cavity was covered with absorbable hemostatic film. Dura was closed. Bone flap was reapproximated. Post-operative MRI scan showed complete resection of a tumor. Patient did well post-operatively with resolution of his preoperative deficits. He subsequently underwent conformal radiotherapy and immunotherapy.